Good day, Miss LJ. For our group, the group 6, we will be discussing the renal diseases. As we all know, the kidney or the main function of our kidney is to filter blood or to remove the waste products. And it is very evident that the kidneys are consistently exposed to substances that are potentially damaging. And it is evident din po na ang urine specimen ay very useful po to aid with the diagnosis and to monitor renal diseases or other diseases. There are 3 classifications of renal diseases according to the primarily affected area of the kidney. So we have the glomerular, the interstitial, and the tubular. For glomerular diseases, ito yung mostly dahil sa immunologic disorders. So, kasi sa immunologic disorders, we have immune complexes na nagkakos ng damage sa glomerulus. So, ang examples ng immune complexes ay immunologic reaction, increased serum immunoglobulin A, IgA, and complements of the immune system such as complement, neutrophils, lymphocytes, monocytes, and cytokines. And pwede din yung cellular infiltration or proliferation. So, dito meron tayong thickening of the glomerular basement membrane. Nagpo-produce ng damage or changes sa glomerular membrane yung mga immune complexes. So, aside sa immunologic causes, meron din tayong non-immunologic causes. Ang mga possible causes ng non-immunologic ay exposure sa chemicals and toxins, which includes drugs or mga in-intake natin mga antibiotics and such, kasi consider din sila na toxins, and deposition of amyloid material from systemic disorders. So yung amyloid, it is defined as the aggregates of proteins that become folded in shapes that allows many copies of that protein to stick together, forming aggregates. And then another cause din ay basement membrane thickening. Okay, so sa glomerulonephritis naman natin, this is referred as the sterile inflammatory process that affects the glomerulus. So, associated siya sa inflammation within the glomerulus. And meron siyang 3 findings: blood, protein, and cast. Since ang major function ng glomerulus natin ay to filter blood, kapag merong inflammation, the function will be impaired. So, yung inflammation, yun yung indication ng damage. And since impaired nga yung function, the proteins, specifically the albumin, will be able to pass dahil sa damage and dahil sa impaired function, and magkakos siya ng damage sa basement membrane. So, associated siya sa blood, sa findings sa blood, kasi may bleeding, so magkakaroon ng hematuria. And yung increase naman ng proteins may possibly be caused by cast in urines, kasi yung cast ay nag-originate sa kidneys. And then, remember na yung Horsfall protein natin ay yung matrix ng protein or matrix of protein. So, sa glomerulonephritis naman natin, pwede siyang mag-progress from one form to another. So, pwede siyang maging acute glomerulonephritis, tapos pwede maging renal failure. Or from simple damage to glomerulus, pwedeng mag-lead sa nephrotic syndrome. And then, pwedeng maging renal failure. So, yung nephrotic syndrome natin, broad term siya sa disease that affects the whole nephron. We all know that the nephron is the functional unit of the kidney. So, ayun, pwede siyang mag-progress into renal failure. Ayan, so for our acute post-streptococcal glomerulonephritis, nangyayari to after ng exposure sa toxins produced by Streptococcus pyogenes in particular. So, ang Streptococcus pyogenes natin is a gram-positive cocci in chains that causes fever and is also a flesh-eating bacteria which invades the deeper tissues and organs. So kilala siya as fever-producing bacteria, flesh-eating bacteria, and associated siya with rheumatic fever. So yung rheumatic fever natin, ito yung inflammation of the heart, joints, and blood vessels because of the complication of the pharyngitis. So, ayun nga, si Streptococcus pyogenes ay nagkakos ng respiratory disorder. So, si acute post-streptococcal glomerulonephritis or AGN in short ay nangyayari dahil na-expose sa M protein sa cell wall ng Streptococcus pyogenes. Kaya nag-cause ng immune complexes or immune responses and nagkakaroon ng deposition sa glomerulus which causes damage. Although manageable naman ito, symptoms niya ay merong fever, edema around the eyes, hypertension, and oliguria. Oliguria kasi dahil nga may deposition sa glomerular basement membrane, so nagkakaroon ng blockage yung sa urine. So, ang primary na makikita sa urinalysis result ng patient with post-strep AGN or AGN ay marked hematuria, proteinuria dahil sa deposition nga ng immune complexes, oliguria dahil ulit sa deposition ng immune complexes na nagbablock ng glomerular filtrate, RBC Cas dahil sa increase na presence ng blood, dysmorphic RBC dahil sa damage sa kidney, and then hyaline and glomerular cast and WBC cast. After mag-subside ng toxicity, magiging normal yung macroscopic evaluation ng urinalysis. Pero sa microscopic evaluation, magkakaroon tayo ng or makikita natin yung microscopic na hematuria. So, makikita natin yung, microscopic hematuria pero hindi na kasing lala nung sa nauna, sa primary stage. Kaya it subsides. Other lab tests na ginagawa sa cases ng post-strep glomerulonephritis ay blood urea nitrogen or BUN kasi elevated to sa acute stages ng AGN. And then anti-group A strep enzyme. So kasi ang Streptococcus pyogenes ay belong sa group A. So aside kay acute post-streptococcal glomerulonephritis, we have rapidly progressive crescentic glomerulonephritis. So more serious siya as compared kay AGN kasi ito ay may poor prognosis or ibig sabihin no prominent signs and pwede siyang mag-lead into renal failure. Ang symptoms naman ng disorder na ito ay initiated by deposition of immune complexes. And ang complication naman na pwedeng mag-develop dito ay another form of glomerulonephritis, again, pwede din mag-lead sa renal failure. Ang patients din na may immune systemic disorder ay pwede mag-develop ng RPG or rapidly progressive glomerulonephritis. For example, yung SLE or systemic lupus erythematosus. And ayun nga, si RPG, unlike kay AGN na manageable, si RPG naman ay nagkakos ng permanent damage sa capillary tufts. And ang permanent damage sa capillary tuft may produce crescentic formation containing macrophages, fibroblasts, and polymerized fibrin. So, ayun nga, again, nadadamage yung capillary tuft and nagkakaroon din ng damage sa capillary walls and nagpa-progress into chronic glomerulonephritis and renal failure. So, ang lab results na associated sa RPG ay markedly elevated protein levels. Ito ay nakikita sa renal failure. And another one ay very low glomerular filtration rate, increased fibrin degradation, deposition of IgA and immune complexes in the glomerulus. For the good pasture syndrome naman, merong morphologic changes sa glomeruli na similar sa RPG. And viral infection causes respiratory symptoms which includes hemoptysis and dyspnea. It can lead to chronic glomerulonephritis and worst sa end-stage renal disease or ESRD. Ang lab findings naman para kay good pasture syndrome ay macroscopic hematuria, proteinuria, RBC cast, and anti-glomerular basement membrane antibody. Kasi merong attachment ng autoantibody sa basement membrane followed by complement activation na nagpo-produce naman ng anti-glomerular basement membrane antibody. So, ang specimen naman na ito o itong antibody na ito ay nadidetect sa serum. Ayan, for the nephrotic syndrome naman, ito ay nakikita sa massive proteinuria greater than 3.5 grams per day. Ang acute onset naman ng disease na ito ay nakikita sa instances ng circulatory disruption na nagpo-produce ng systemic shock na nagde-decrease or nakikitaan ng decrease sa pressure and flow of blood sa kidney. Ang progression to nephrotic syndrome may also occur as a complication of other form of glomerulonephritis. So, ito yung nabanggit natin kanina sa glomerulonephritis na introduction. And ang depletion naman ng albumin ay nag-increase ng fluid loss sa interstitial spaces accompanied by sodium retention na nagpaproduce naman ng edema. For chronic glomerulonephritis naman, yung amount and duration ng naging damage natin sa glomerulus na na-discuss natin sa mga naunang disorders, pwede siyang mag-progress sa chronic glomerulonephritis. And yun na nabanggit ko kanina sa end-stage renal disease. So, kapag napabayaan yung deposition sa glomerular basement membrane and maapektuhan ng matagal yung glomerular filtrate natin, magpaprogress siya into chronic glomerulonephritis. And ang gradually worsening symptoms naman nito ay fatigue, anemia, hypertension, edema, and oliguria. So, ang urinalysis nito nagre-reveal ng hematuria, proteinuria, and glucosuria. For immunoglobulin A nephropathy, immune complex containing IgA are deposited on the glomerular membrane and causes glomerulonephritis. So, as we discussed nga earlier, yung mga immune complexes natin ay na deposit sa ating glomerulus and nagkakasya ng damage and changes sa glomerulus and nagkakaroon ng blockage sa filtrate natin. So, nagkakaroon tayo ng iba-ibang symptoms such as oliguria or yung pagkakaroon ng lesser na pag-produce ng urine dahil nga meron tayong blockage sa glomerular filtrate.
Next is the tubular disorders. These disorders affects the renal tubules, which tubular functions are disrupted, resulting actual damage to the tubules. So, nakukuha natin ang mga disorders na to through metabolic or hereditary. Then we have ATN. ATN, it is a primary disorder associated with damage to the renal tubules. Damaged RTE cells resulted from decreased blood flow, which oxygen presentation in the tubules is or are inadequate or reduced, known as ischemia. Also, toxic substances or agents are present in the urinary filtrate. Since ATN can be caused by ischemic ATN and nephrotoxic agents, the following under the ischemic ATN includes shock, trauma, or crushing injuries, and surgical procedures. For example, severe conditions include cardiac failures, sepsis involving toxigenic bacteria, anaphylaxis, massive hemorrhage, and contact with high voltage electricity. For nephrotoxic agents, this includes aminoglycoside antibiotics, antifungal agent amphotericin B, cyclosporine, and radiographic dye. For organic solvents, we have ethylene glycol, heavy metals, and toxic mushrooms. Also, large amounts of hemoglobin and myoglobin. For its clinical course of ATN, this includes ischemia correction, toxic elements removal, and managing the accompanying symptoms of ARF, are ways for complete recovery of ATN. For its urinalysis findings, mild proteinuria, microscopic hematuria, RTE cells and RTE cell casts, and casts such as hyaline, granular, waxy, and broad. Then we have hereditary and metabolic tubular disorders. These are disorders affects tubular function caused by systemic conditions that affect or override the tubular reabsorption maximum or TM for particular substances normally reabsorbed by the tubules, and failure to inherit a gene or genes required for tubular reabsorption. Then we have the Fanconi syndrome. It is the most frequent disorder associated with tubular dysfunction, wherein generalized failure of tubular reabsorption in the proximal convoluted tubule is occurred. With this, tubular reabsorption may be affected by dysfunction of the transport of filtered substances such as glucose, amino acids, phosphorus, sodium, potassium, bicarbonate, and water across the tubular membranes, or disruption of cellular energy needed for transport, or changes in the tubular membrane permeability. Its etiology: it is inherited in association with cystinosis and heart-valve disease. Toxic agents such as heavy metals and outdated tetracycline. and complication of multiple myeloma or renal transplant. For its urinalysis findings, we have glycosuria, mild proteinuria, or low urinary pH due to the failure to reabsorb bicarbonate. For Alport syndrome, it is an inherited disorder of collagen production. It is sex-linked and and it is a autosomal genetic disorders wherein males inheriting the X-linked gene is affected more severely than females inheriting the autosomal gene, where thinning gr- glomerular basement membrane occurs. For its clinical course, we have persistent hematuria, proteinuria, and renal insufficiency in later life to nephrotic syndrome and ESRD. For uromodulin-associated kidney disease, kailangan muna natin malaman kung ano nga ba yung uromodulin. It is a glycoprotein in the proximal and distal convoluted tubules. So yung disease na to, it is an inherited disorder caused by an autosomal mutation in the gene that produces uromodulin. So its etiology, the production of normal uromodulin and abnormal uromodulin is decreased, and serum uric acid causing gout is increased, which is the onset of detectable renal disease. For its clinical course, we have renal function monitoring and then renal transplantation. Next is the diabetic nephropathy. It is the most common cause of ESRD, which gives damage to the glomerular membrane, whereby glomerular membrane thickens. So with this, it is proliferation of mesenchymal cells and deposition of cellular and non-cellular material within the glomerular matrix is increased. Therefore, accumulation of solid substances around the capillary tufts occur. For its clinical course, early monitoring of people with diabetes mellitus, and then modification of diet and strict control of hypertension that decreases the progression of the renal disease. Next is the nephrotic diabetes mellitus. Nephrotic diabetes mellitus is inherited as a sex-linked recessive gene or acquired from medication, complication of polycystic kidney disease, and sickle cell anemia. For its urinalysis findings, we have low specific gravity, pale yellow color, and the results for chemical test, possible na false negative siya. And lastly, in tubular disorders, we have renal glycosuria. So renal glycosuria is generalized failure to reabsorb substances from the glomerular filtrate. Also, it is an inherited autosomal recessive trait. For its urinalysis findings, we have glycosuria, and with this, the number of glucose transporter and the affinity of transporters for glucose are decreased. Also, urine glucose concentration with normal blood glucose concentrations is increased.
Next topic will be the institutional disorder, in which we're going to discuss from UTI to acute pyelonephritis, chronic pyelonephritis, and acute interstitial nephritis. So first, we have the urinary tract infection, in which the most common renal disease infection will involve the lower urinary tract, or the urethra and the bladder, or the upper urinary tract, renal pelvis, tubules, and interstitium. UTIs occurs when bacteria or other microorganisms enter the urinary tract and start to multiply. The most common cause of UTIs is the bacterium Escherichia coli or E. coli, which is normally found in the intestines. However, other bacteria such as Staphylococcus saprophyticus and Klebsiella pneumoniae can also cause UTIs. Most frequently encountered infection of the bladder is the cystitis, which can progress to more a serious upper UTI if left untreated. Cystitis is more often in women and children who presents with symptoms of urinary frequency and burning. Renalysis reveals the presence of numerous WBCs and bacteria, often accompanied by mild proteinuria and hematuria and an increase in pH. Next, we have the acute pyelonephritis, infection of the upper urinary tract, including both the tubules and the interstitium. It is termed pyelonephritis and occurs in both acute and chronic forms. Acute pyelonephritis occurs most frequently as a result of ascending movement of bacteria from a lower UTI into renal tubules and interstitium. Patient present with rapid onset of symptoms including urinary frequency, burning on urination, and lower back pain. The ascending movement of bacteria from the bladder is enhanced with conditions that interfere with the downward flow of urine from the ureters to the bladder or the incomplete emptying of the bladder during urination or yung painful urination natin. This includes obstructions such as renal calculi, pregnancy, and reflux of urine from the bladder back into the ureters. Next is the chronic pyelonephritis. Chronic pyelonephritis is a serious disorder that result in permanent damage to the renal tubules and possible progression to chronic renal failure. Congenital urinary structural defects producing reflux nephropathy are the most frequent cause of chronic pyelonephritis. The structural abnormalities may cause reflux between the bladder and the ureters or within the renal pelvis, affecting emptying of the collecting ducts. Due to its congenital origin, chronic pyelonephritis is often diagnosed in children and may not be suspected until tubular damage has been advanced. As this disease progresses, a variety of granular and waxy and broad casts are present, accompanied by increase in proteinuria and hematuria, and renal concentration is decreased. Lastly, we have the acute interstitial nephritis or AIN. It is marked by inflammation of the renal institution followed by inflammation of the renal tubules. Patient present with a rapid onset of symptoms relating to renal dysfunction including oliguria, edema, decreased renal concentrating ability, and possible decrease in glomerular filtration rate. Fever and the presence of skin rash are frequent initial symptoms. AINs associated primarily with allergic reaction to medication that occurs within the renal interstitium, possibly caused by the medication binding to the interstitium protein. Symptoms tend to develop approximately 2 weeks after administration of medication. This medication commonly associated with INS include penicillin, methicillin, ampicillin, cephalosporins, rifampicins, sulmonifides, NSAIDs, antacids, diuretics. Other drugs that are implicated commonly include indapamide, proton pumps, allopurinol, diuretics, and cimetidine. Discontinuing the offending medication and administering steroids to control the inflammation frequently results in a return to normal dysfunction. However, supportive renal dialysis may be required to maintain patient until the inflammation subsides. The analysis results includes hematuria, possible microscopic mild to moderate proteinuria, numerous WBCs and WBC cast without bacteria.
And now let us move on to renal failure and renal lithiasis. But first, I will be discussing about renal failure. So, renal failure has two forms, namely acute renal failure and chronic renal failure. Acute renal failure exhibits a sudden loss of renal function and is frequently reversible. In the past, acute renal failure or ARF was also known as acute kidney injury or azotemia. Azotemia may happen whenever the kidneys have become impaired by sickness, injury, or medications, and they lack the capacity to eliminate sufficient amount of nitrogen waste in the body.
This will result in the BUN or blood urea nitrogen and creatinine elevations due to kidney problems. We have three types of azotemia. The first is the pre-renal. From the word itself, happens before the kidney. Due to decreased renal perfusion, the kidneys are unable to remove enough metabolic byproducts from the blood. So, take note po natin yung examples. Ayan, tulad ng decreased blood pressure or cardiac output, hemorrhage, burn, surgery, and septicemia. Kung mapapansin po natin, outside ng kidney yung problem. Next is renal azotemia. This means that the problem lies within the kidneys. Examples are acute glomerulonephritis, acute tubular necrosis, acute pyelonephritis, and acute interstitial nephritis. Lastly is post-renal azotemia, wherein it is caused by ureter and bladder problems. Typically, the individual has some sort of blockage being diagnosed. An example of post-renal azotemia is renal calculi. Next is chronic renal failure, gradual progression of original disorder to chronic or end-stage renal disease. So, it simply means that mas malala na siya. There are 7 characteristics of chronic renal failure. First is the marked decrease in the glomerular filtration rate less than 25 ml per minute. It is important to note that our glomerulus is the one that filters plasma to become urine. This serves as a non-selective filter of plasma substances having a molecular weight of less than 70,000. Thus, decrease in the GFR will result in the inability of the glomerulus to filter what it needs to be filtered effectively. Second is the steadily rising serum, BUN, and creatinine values or azotemia. Like in acute renal failure, azotemia may also happen in chronic renal failure. Third is electrolyte imbalance. Since there is a decrease in renal perfusion, there will also be a decrease in aldosterone formation. Note that the hormone that is responsible for the renal perfusion is the renin, which stimulates the activation of renin-angiotensin activation system or RAAS. This system is responsible for the production of aldosterone and promotes the reabsorption of sodium. In case of renal failure, decreased production of renin will decrease the stimulation of RAAS, thus decrease the aldosterone production and decrease sodium reabsorption. More potassium is being reabsorbed in exchange for the loss of sodium in the urine. Fourth is lack of renal concentrating ability, producing an isothenuric urine. Along with loss of sodium in urine, water reabsorption is also reduced. The kidney cannot concentrate urine due to increased urination, so isothenuric urine is the result. And then we have also proteinuria and renal glycosuria. In normal cases, small to negative amounts of proteins can be seen in urine. However, due to the defects in the glomerulus, it cannot filter the proteins, primarily the albumin and glucose, effectively, which now cause the loss of these analytes in the urine. Lastly is the abundance of granular, waxy, and broad casts, often referred to as a telescope urine sediment. This may be seen along with the progression of acute renal failure to chronic renal failure.
Alright, so now for the last part of our report, let's talk about renal lithiasis, wherein the term lithiasis refers to the presence of stones that can originate in any part of the urinary tract. So what is renal calculi? Well, renal calculi are also called crystalloids embedded in a binding substance of mucus and protein, which also contains inclusions like bacteria and epithelial cells. Alright, so now for the last part of our report, let's talk about renal lithiasis, wherein the term lithiasis refers to the presence of stones that can originate in any part of the urinary tract. So what is renal calculi? Well, renal calculi are also called crystalloids embedded in a binding substance of mucus and protein, which also contains inclusions like bacteria and epithelial cells. And lithotripsy is the procedure that uses high-energy shock waves that can be used to break stones located in the upper urinary tract that can be passed in the urine. Now, here are the conditions favoring the formation of urinary crystals. We have pH, chemical concentration, and urinary stasis. While urine pH has an important impact on the appearance of different kinds of kidney stones. And in an alkaline pH level, it supports the formation of crystals of calcium as well as phosphate-containing crystals, while an acidic pH increases uric acid and cysteine stones formation. Now, for the chemical concentration, when the chemicals released by the kidneys are oversaturated, it may contribute to the formation of renal stones, which might also cause obstruction. And for the urinary stasis, stagnant urine or urines that has stayed in the urinary bladder for a long period of time is a particularly common lithogenic factor that coexists with blockage and contributes to the infection. Now, what is the constituent of renal calculi? Well, calcium oxalate is the major constituent of renal calculi, and this is frequently associated with metabolic calcium and phosphate disorder and occasionally diet. For the appetite, it can be in the form of calcium, magnesium, phosphate, and carbonate, while triple phosphate, which can be in the form of calcium, magnesium, phosphate, carbonate, and ammonia. We also have uric acid and urate. Now, what are the tests done in renal calculi? Well, we have the spot plate test, wherein the constituent of renal calculi like uric acid has the chemical reagent of sodium carbonate, and it gives a deep blue color for the positive result and a negative pale blue color. We also have oxalate, which has the hydrochloric acid and magnesium as its chemical reagent, and it gives a positive result with the formation of tiny bubbles. We also have phosphate, which has the chemical reagent of ammonium molybdate over flame, and it gives a positive distinct yellow precipitate. We also have carbonates, which has the hydrochloric acid as its chemical reagent, and it gives a positive result with a foaming effervescence. And we also have calcium, which has the chemical reagent of sodium hydroxide, and it gives a positive fine white precipitate. We also have magnesium, which has the sodium hydroxide and magnesium as its chemical reagent, and it gives a slow formation of blue precipitate for the positive result. We also have ammonia, which has the sodium hydroxide plus Neisser's reagent as a chemical reagent and gives a yellow-orange precipitate as a positive result. We also have cysteine, which has the ammonium hydroxide and sodium nitroprusside reagent, and it gives a red color for its positive result. We also have the uric acid test, which is a method for determining the presence or absence of caffeine along with other purine-deprived compounds in a specimen. And this uses various test reagents like sodium hydroxide and ammonium hydroxide. Now, for this specific test, we have the constituent of renal calculi like uric acid. And the reaction in uric acid test for uric acid gives a deep yellow to orange, red, or crimson purplish upon the addition of ammonium hydroxide, and blue-violet upon the addition of sodium hydroxide. We also have the xanthine, which has the greenish yellow, orange upon the addition of ammonium hydroxide, and a deep orange-red upon addition of sodium hydroxide. And lastly, we also have protein, which gives a pale yellow turning orange, and sulfonamides, which gives off a mahogany brown color. That would be the end of our report. Thank you so much for listening.